I want to thank you all to the Network Commons. This is the Build Healthy Places Network's live discussion series on cross-sector strategies to improve neighborhood health and well-being. I hope that many of you joining today's call have had the opportunity to participate in one of our other Network Commons events. But if you haven't had a chance to listen in before, we model these events like panels at a conference with a presentation from experts and time for questions and answers from you, our audience members, at the end. We look forward to hearing your thoughts. My name is Doug Judy. I'm Executive Director of the Build Healthy Places Network. Our mission is to shift the way organizations work across the health, community development, and finance sectors to collectively advance equity, reduce poverty, and improve health in neighborhoods across the United States. I'm also a pediatrician by training and teach at UC Berkeley in the School of Public Health. Today I have the honor of serving as moderator for our discussion. We're lucky to be joined by 3 leaders of coalitions taking regional approaches to improve health, enhance opportunity, advance equity across the country. In Atlanta, Chicago, and the Bay Area, these leaders and their organizations are working across the sectors of health and community development, sometimes crossing geopolitical boundaries of cities and counties, sometimes following community patterns across healthcare catchment delivery areas. These innovative regional approaches promise new opportunities for inclusive economic growth by addressing some of the persistent social inequities that contribute to the social determinants of health. In building their regional coalitions, we'll hear about what strategies they've used to engage diverse stakeholders, the challenges and successes they've experienced with these efforts, and we're going to look for similarities and differences across their regional approaches and learn about how the regional approach has strengthened their work. To provide resources that come up in the discussion in real time, we'll be providing links in the chat box. We'll start now with links to the full backgrounds of our speakers. But in addition to the bio that we'll link in now, I want to introduce our speakers. So first, I'd like to welcome Catherine Lawler. Catherine is the Executive Director of the Atlanta Regional Collaborative for Health Improvement, or Archie. Archie is a broad collaborative consisting of more than 100 diverse organizations, agencies, and individuals, and they employ a dynamic systems model to improve health of low-income neighborhoods across the city of Atlanta. Next, I'd like to welcome Jess Lynch. Jessica is Program Director for the Chicago-based Alliance for Health Equity. The Alliance is a collaborative of over 30 hospitals, partnering with local health departments and regional and community partners to address community health priorities in the city of Chicago and surrounding suburban Cook County. And finally, a little closer to home for us, I'd like to welcome Melissa Jones, who is the Executive Director of Barfight. Barfight stands for the Bay Area Regional Health Inequities Initiative. Barfight is a coalition of 11 public health departments located around the San Francisco Bay Area, working together to use an explicit racial justice lens to advance health equity. So I want to thank you all for coming. I'm really pleased to have you here today. And I also want to thank all of you who've joined us online and are watching from across the country. We actually had over 720 folks register, so we've definitely hit upon an area of interest nationally. But before we start, just a quick note about technology for today's webinar. So we're using Zoom, and there are 2 features that we can use on the bottom bar. On the middle left, you'll see a Q&A button, and a bit to the right, you'll see a chat button. We're going to use these differently. So to provide questions for our speakers, you can send us those through the Q&A feature. If you have any technological issues or to see the materials that we'll upload, use the chat feature. That way we can troubleshoot with you if there's problems. So again, Q&A if you have questions, makes sense, and chat if you have technological issues, and to look for resources. So as we've done in the past, I'm going to kick off with just a couple questions for our speakers, and then we'll move on to our audience and get to your questions. We're grateful many of you submitted thoughtful questions as you registered, and we'll try to get to those. You can also submit questions, as I mentioned, with the Q&A. In addition, we're going to be monitoring Twitter. So if you'd like to send us a question or retweet something or tweet something that you've heard that you like, do that and use the hashtag #NetworkCommons, all one word. It's hashtag #NetworkCommons. We'll try to get to as many of those as possible. All right, so good. Today I'd like to start and open our discussion by first asking our panelists to provide an overview of their organizations, how they're structured, staff funded, where they came from, all that. So Catherine, let's start with you. Can you give us a brief introduction to the Archie Collaborative in Atlanta, how it was founded, what were the motivating factors, and some of the other sort of background?
Yes, and it's wonderful to be here with everyone. Archie came together when a number of leaders recognized that our state would not be pursuing Medicaid expansion in the ACA. This was in the early days in 2011, But there were many other opportunities that we wanted to continue to explore to get at some of the overall goals of improving health in our community. And initially, it centered around helping health systems coordinate their community health needs assessments, but quickly evolved into helping organize new ways of working that could address those issues that were emerging in those assessments. So in 2012, through a series of meetings of large stakeholder groups, over 70 groups came together to establish Archie's 7 core priorities and make a 28-year commitment to driving those priorities in order to make substantial change in our metro area. It won't surprise anyone here that what we know works and what emerged in those priorities is a strong emphasis on the social determinants of health and getting at underlying health inequities that have plagued our community for a very long time and addressing those in an upstream way so we could start to make some substantial change. So Archie has been together since then and is continuing to move forward. Just some of the nuts and bolts, we have 4 full-time staff, 2 part-time staff. We serve the metro area but concentrate specifically on Fulton and DeKalb counties. If you've ever been to Atlanta, that's the counties that the city is actually located in, but it has a large number of health systems and payers. Doug mentioned that we now have over 100 organizations who are aligning their organization's goals and resources to the 28-year commitment. And about 30% of those would be considered the formal healthcare sector, but the other 70% intentionally represent the full spectrum of social determinants of health, housing and transportation, community services, the whole gamut of organizations. We have a lot still left to do, but it's been exciting to see as the momentum has grown.
That's great, thank you. Yeah, you know, one thing, I just want to repeat something you said, Catherine, which is your 28 years of commitment. That length of consistent support is, I think, a really critical issue. And I'm going to have our team upload right now a link to what we call the Principles for Building Healthy and Prosperous Communities that we published recently. The reason I mention it is because we did a synthesis of the value statements, the priorities of 35 organizations across health and community development, because we were seeing so much consistency. What we came up with were 5 principles, and one of which is commitment over the long term. So I think you just demonstrated that here. Jess, let's turn to you next. Can you tell us a little bit more about what's behind the Alliance for Health Equity in the Chicago area and what motivated this particular regional creation?
Great, thanks so much. So the Alliance for Health Equity, as Doug mentioned at the beginning, is a collaborative of hospitals, health departments, and community and regional partners working together. We currently have 37 nonprofit and public hospitals working together with cross-sector partners, and the Chicago and Cook County Departments of Public Health are really also crucial leaders in this effort. We at the Illinois Public Health Institute provide sort of the convening or backbone function to the collaborative. Just to give a little context for Cook County, Illinois, we are approximately 5.2 million residents in Cook County, roughly split half between the city of Chicago and surrounding suburbs. And we have about 135 municipalities in the suburban Cook County, in addition to 77 community areas in the city of Chicago. So while we're talking about a county, it is really a region when you think about the complexity of the population there. Also similar to a lot of other metro areas across the country, we have massive issues with health inequities and really a need to work toward health equity and racial equity in our city and county, with up to 30 years of life expectancy differences between different communities, which I know is similar to many of the folks who are listening in. So similar to what Catherine was sharing, the Alliance for Health Equity did also grow out of a desire to work on a collaborative community health needs assessment process across hospitals and health departments. Also, similarly, we had a lot of champions and leaders within our health systems and other partners that really saw this as an opportunity to go beyond working on assessment together and really try to address some of the upstream factors that impact health equity in our region. So we're we're the youngest of the 3 collaboratives here. And so we came together in 2014. One thing I think I'll highlight, and we can talk about a bit later, is that we operate on a mixed funding model. So we do have a membership funding for the collaborative that comes through the hospital members. And then we also do resource development to support specific projects. And we're coming up on our third membership cycle for the collaborative. So we're excited about sort of the sustainability of this funding model. Some of the key issues that we're working on are housing, community safety and violence prevention, mental health, trauma-informed care, and food access. And we can get into some of the specifics later on.
Great, thank you, Jessica. So Melissa, let's turn to you. Barfight is interesting because it started out as sort of an informal conversation to become a mature organization. Can you tell us about sort of that start and where you are now?
Sure. So Barfight started in 2002 and really a little bit before that in a series of conversations among first 4 public health directors in the 9-county Bay Area, really looking at their data and being concerned about the same health inequities that Jessica and Catherine are talking about. And they developed together a way of understanding what was happening and what the change could be, called the Barfight framework, which we'll share with you here. And that framework really highlighted that the living conditions that influence health and the social inequities that underlie the reason that we have so many differences in the living conditions we experience. You'll see it here now. The middle block showing the living conditions that are impacting our health far before we get to a doctor's office, the institutional inequities that have created those living conditions, and the social inequities that allowed them at first to occur, as being the fundamental ways that we need to transform our system. And so the group began to focus on a set of activities, and you'll see them there: strategic partnerships, advocacy, community building, community organizing, and policy, that would really allow the 9-county Bay Area to transform the living conditions that are impacting health. And so thank you for sharing the framework. The counties went from that initial focus on the framework and set of dialogues into the hiring of staff people inside the public health departments that understood different social determinants. And each county focused more deeply on some than others. But really with this frame around this framework being what was in strategic plans, what's in community health improvement plans to drive a change in how we all live in our living conditions. When those new staff were brought together, we began a process of having communities of practice for the staff that were focused on the upstream social determinants of health. And so at that point, our coalition grew from being informal to having staff people who ran communities of practice on behalf of the 9-county membership. We then grew further as the group got more and more interested in doing regionalized policy work. And so we're now an organization of about 10 staff people, which allows us to have a staff person focused on each of the primary areas that as a region, the public health departments are seeking to move forward. So housing affordability in health, climate change in health, early childhood, differences in early childhood and maternal birth outcomes, and economic opportunity. And that is the way that our model works today. Our model includes membership dues from each of our member health departments, earned revenue, which we earn through trainings to members who are not part of our public health membership network that funds our policy and lobbying efforts, and then foundation grants.
Great. No, I think it's really fascinating, the different, each of you are regional, but very different sort of histories and developments. And I think for our audience, the goal is to see that it can vary from place to place. And I'll encourage anyone listening, I'm sure our speakers, I'm going to say, would be happy to talk further about their particular history. I wanted to, are we able to put up the slide that didn't show earlier? So Catherine, your slide didn't pop up earlier. Do you want to say a bit about it if we get the visual up? Apologies for that. I just learned that. Okay, now it's up. Oh, are you on mute, Catherine?
This is just an image that characterizes how those 7 priorities and just a handful of the quantified goals that we expect to achieve by pursuing our 28-year commitment. So we have on the left our core beliefs about the Atlanta region, that we are actually a place that is incredibly rich in resources, skills, and expertise, but our consistently poor health outcomes are the result of a misalignment of those resources and continued policies and practices that leave certain groups out. And in the 4 gears, you can see some of those are 4 of the 7 priorities, and the 3 that are near the arrows represent the way that we know that we have to drive the change in funding. So you can see the social determinants. And then on the right-hand side, we actually have a whole list of the goals that we expect to achieve, but it just gives you a sense of some of those. And being able to quantify our intended outcomes in this way has been incredibly helpful, particularly as we have worked to bring together parts of our community to understand that it isn't just about improving health, but it's ultimately about economic improvement as well. So that's been one of the assets of having the opportunity to lay out our priorities in this way.
Mm-hmm. Yeah, that's really great. And I think the focus on how things are paid for and the value, as you're suggesting, of this work is really critical. The financing, we have to figure out how to make health financeable. Oh, Melissa, I wanted to mention, what was your good news today or recently?
Barfight and some work we've been doing in one of our counties, in particular Solano County, has just been awarded a Build Health Challenge grant, which we're thrilled about, that will continue to advance our housing affordability and health work in a part of the region where people have been moving because it's still more affordable than other parts of the region for housing. And so it's a way to get ahead of the housing market there and hold it to continue to be affordable. And I can talk later about all of the ways we know that's impacting people's health.
Great, so thank you. Yeah, and that can be, you'll, actually maybe we can, my team can put up Build Health Challenge, like the website, so you can see, we'll look for that right now. So yeah, let's move on to a second question. So I wanted to just dig a little deeper, talk about the strengths of the regional approach from your perspective. What are some of the advantages you see in terms of tackling poverty and community health? And similarly, are there downsides to working on a larger geographic and population level? So Jessica, why don't we start with you?
Great. So as a regional organization from the beginning, the Alliance for Health Equity has really recognized the importance of supporting both policy and systems change at the regional level, as well as making sure that we're actually opening up more opportunities for local efforts that are driven by and led by local communities. And so as a result, a lot of our work is actually about coordination and alignment. I wanted to share one tool that we found helpful, which is the collaboration spectrum that Teramac Institute in Canada has put together. So I don't know if we have it on a slide, or otherwise we can send it as a link. But we have found that as we're thinking about our work as a regional entity, that often we're working sort of along this spectrum. Not everything that we're doing are we really trying to work towards full integration or collaboration. In some cases, actually communication or cooperation can be as important, particularly in areas where we are not necessarily the leader as our coalition, but rather supporting the efforts of other entities. So I'll give a quick example. One of the reasons that we started taking the regional approach was that we realized that there were a lot of overlapping efforts in the community assessment and planning space that were asking community partners to come to multiple tables to give input around very similar topics. And so in being able to cooperate across not just our countywide effort, but also with specific efforts happening on the west side of Chicago or South Suburban Cook County, we're able, and with the health departments as well, we're able to make sure that the input that communities are providing is informing planning and implementation of initiatives that is happening across, or is being led across by different entities. So this tool has been helpful for us in thinking about where we place different initiatives across this collaboration spectrum. One of the other things that we have found as we're doing this regional work is that in order for us to really advance health equity and racial equity, we recognize that the regional work must also increase community-driven change, and that's really challenging to do sometimes as a regional organization, or at least we have found that to be challenging. So one thing that we try to do is be very transparent about what the opportunities are for community leadership within the work that we're doing, and also help to support other efforts that might be more localized, where there's also opportunities for folks to engage. So as an example, we have developed a county-wide healthcare and food access action agenda that is looking at how healthcare and food access organizations can partner both at a policy and systems level. So we found that a number of things do have to happen at that regional level or even the state level in order to open up more opportunities for local procurement of locally grown food, for example. But we also need to pair that with specific partnerships between healthcare institutions and community-based organizations on the ground to establish those local procurement relationships. So we're really trying to figure out the best ways to work at both the regional and the local level to support an agenda that will drive change.
Super. Yeah, I could see Melissa and Catherine nodding, which is the advantage of a webinar as opposed to just slides. Melissa, why don't we turn to you next? Can you tell us a little bit about specific projects you're working on?
Yeah, we've really found, similar to Jess, that there are some common challenges for us as a region across the 9-county Bay Area. A big one is housing affordability and health, where we're seeing that the combination of a lack of tenant protections, having people who are earning very high incomes and very low incomes, and not having enough housing have created a housing crunch that have driven up the cost of living for many, many families. And that cost of living then is taking from people's ability to spend on things we know promote health, including food, healthcare, and services for their family and childcare. We also have in our region a series of issues around the current impacts of climate change, particularly an increasing number of high heat days in a row, which create problems for people who are medically vulnerable. Increased numbers of fires and sea level rise that sees flooding in some of our low-lying areas that gets into people's houses and creeps in and sits as mold. And so to really get to solutions, root cause solutions on these issues, we need policy solutions. And the Bay Area is large, it's 7 million people, it's 9 counties and 101 cities. And so to advance policy change in each of those cities requires a level of community organizing in each city that some cities just don't have the capacity for and requires a whole lot of duplication. And so that we're lucky that the Bay Area, like actually many regions, have a regional planning organization focused on housing and transportation at a regional level. And so we regionalize what their decisions mean for public health through the public health departments, and then work together through the public health departments and our coalition on regional strategies to help shape what's needed on housing and issues like climate change. The other thing we do is choose when there are times that the coalition should be working in combination with other partners and community organizing groups to advance a solution statewide to create a base level of healthy protections for people. And we've actually just done that. We've spent the last year facilitating an equity kitchen cabinet focused on a regional housing planning process that was advancing here in the Bay Area called CASA. And through that process, we're able to come up with a set of 3 key priorities that could transform housing affordability for our region, and worked alongside tenant advocates, nonprofit housing providers, businesses that care a lot about housing and want their employees to be able to stay in the area, and advanced statewide anti-rent gouging bill that will protect families from sudden shocks in rent. That is going into place now that will mean families can predict what their rent is from month to month, and we won't have sudden risks of homelessness or housing instability for families, and we're thrilled about that. And that's the reason we work regionally. The one other reason that we're really focused regionally is what we found is across the 9-county Bay Area, there is a real shared understanding on the social determinants of health and a real strong adoption of that Barfight framework I sold earlier, but showed earlier. But to move from that understanding into being able to change the actual living conditions on the ground requires a real deep level of expertise. And it's very rare for any health department to be building out their level of expertise in all of these issue areas at once. They might have really strong housing folks or really strong climate folks or really strong people focused on the needs of immigrant communities right now. But it's rare for them to have all of that. And so by working at a regional level and pulling from the expertise in the counties that have focused on the particular issue that's pressing for the region, we can regionalize the knowledge that's in particular set of counties. And so we spend a lot of time taking from the expertise of a few counties who have invested in a particular issue, sharing their expertise regionally through communities of practice, and then also creating policy based on what we know from their expertise. And it benefits the whole.
That's great. Yeah, a lot of important points in there. And I think I told you, Melissa, that I was at some other conference elsewhere in the country, and your diagram showed up with no attribution to Barfight. I mean, it was down at the bottom, but like they were just using it as the model for that conference. So
it's wonderful.
Catherine, let's turn to you.
Up on our
website, I know it's good
and
news,
free
right?
And shared for people to use.
Yeah, actually that's good. Yeah, so if anyone needs it, just download it. Catherine, yeah, let's talk about advantages and disadvantages you've seen in Atlanta.
So our work is organized in two key portfolios of change: the community change portfolio, which works directly with residents and neighborhoods who have experienced high levels of health inequity. So we work with residents to identify what their priorities are and help any combination of the 100 Archie partners align to support that work. The systems change portfolio is really focused on helping health systems learn to work differently and work together to achieve broader community-based outcomes. And so those have manifest themselves in a variety of ways, but all of the work in both portfolios has to be about collective work. So by definition, work that no one organization could do on their own and really wants to do with others, and then that it has to focus on the social determinants of health. So we are all about helping link clinical care to social care, but not focused on making significant changes in the clinical setting, that it's about that bridge. The advantages we have found to working regionally is that people in our community live regionally. We have a lot of counties and cities in our metro area, but they are really quite small, and most people's lives cross those boundaries all the time. In addition, our health systems markets expand. None of them are focused in any one singular geography, but multiple geographies. So that kind of alignment is very helpful. We've also found that other key plans and investments are aligned regionally as well. And so when we made our long-term time horizon of 28 years and we focused broadly on the region, it has been easier to align with economic priorities, transportation investments, because those are also done and made on that scale. I think some of the real advantages to working regionally is that collaboration is very hard. And sometimes it's about timing and getting the right people together at the right time, and that has a lot of influences to what makes the perfect timing. And so having a broader area to innovate in, to try things in, it gives us the variety to continue to grow the momentum, even if timing is not exactly right in one place or one project. It gives us the variety we need to keep moving forward, because a lot of this, it's just very challenging work, and you're contingent upon a lot of people needing to align and work together. And so I think that has been one of the key advantages to working that broadly. The other thing is, by working broadly, we are really able to focus more significantly on systems change, because systems seem to manifest themselves far outside of a single neighborhood, school cluster, or even one public health department. And so that has been a real advantage of it. One of the challenges, I think, and I know Melissa and Jess, we have talked a little bit about this before, but how, when you take on a broad geography, having authentic community engagement is something that requires many, many different vehicles and opportunities, because there is not one single group of community folks, residents, people with lived experiences who can really represent an entire broad geography like that. And so it just requires being incredibly creative and being very thoughtful and consistent about engaging that, so that you have the broad geography, all the variety within it, and that you make sure that you have authentic participation from that broad variety as well. So that would just be something folks may want to discuss later as well.
Mm-hmm. Super, thank you. Well, we're about, let's see, to check the time, we're about half an hour into our hour. So Why don't we turn to some questions from the audience? I have one here that gets to something I know the three of us spoke about. Can you talk about examples of how community economic development has played a role in your regional approach? It's much like a question that we actually intended to have as a third question. So can you just tie in specifically, given our audience is across community development and health, the role of community development, community economic development to your work? I think it'd be good for all of you to answer if you can. So maybe Melissa, start with you.
Sure. Yeah, community economic development is a core piece of our work. So Barfight started with a real focus on the built environment and the changes that could be made to promote people's health, everything from walking to the quality of housing we live in, to our economic opportunities in businesses and ways to get businesses started and have people employed. So, you know, picking up on what Catherine said about authentic community engagement and organizing, the approach that we've taken as a region is to really focus on where community organizing is happening across the region, what community organizers who have their own local bases are saying about what's needed next in the built environment. And so for us in housing, that has meant that there are community organizing groups all across the region who are working with tenants and understanding what they need to ensure that they have homes that are kept up to code, that aren't suffering from issues of mold, that don't have asthma triggers in them, and that they can get the support they need to have those homes improved. And that they're not being, that their rent isn't suddenly being changed. For example, we had a community where we had several hundred people served with notices of a doubling of their rent. In the course of, over the course of a 6-week period. And so being able to prevent that kind of rent gouging from happening. And we get all of that information from deep community engagement in those places. And then we focus on the places in the region that are not yet, that don't have the organizing infrastructure because they receive the least giving in the region. And so don't have that organized infrastructure, and then provide specific supports to them to make sure we understand their needs and issues. And so for us, one of the big community development strategies around that has been to create this 3-piece framework for the region that includes a strong emphasis on tenant protections, the preservation of affordable housing, and the production of new housing. And our region has seen some pretty incredible things, as I know Catherine and Jess have also seen, in terms of both corporations and healthcare together putting into funds that can be used to develop affordable housing. And Catherine and I are funded together in an initiative called SPARK, the Safe, Prosperous, and Resilient Communities Challenge. And for us here in the Bay Area, we've been able to use those resources as seed dollars to expand a land trust that was operating here in the region, that was taking properties that landlords had not kept up and were becoming health hazards, upgrading those homes and then holding them in perpetuity for affordability in a place where we were seeing housing costs really push people out and seeing increased displacement. And so those are some strategies we've seen and are really excited about seeing expand.
Mm-hmm. Yeah, you know, one term that I learned a while ago in affordable housing that those in our audience on the health side might not know is called NOAA, which is naturally occurring affordable housing. Mm-hmm. And so it's really, as what you're describing, poorly kept up, cheap housing that if purchased and then upgraded can make a good home and then be protected long-term through a land trust or through other efforts. Exactly. So this question I think is just so important around the role of community development, community economic development. I just want to turn to Jess and Catherine as well. Maybe Jessica?
Sure. So I'll just share briefly about a few things. I think a lot of the efforts, partnerships between healthcare and community economic development in our region are pretty nascent, but a lot of interesting things that are going on. So one, in the area of housing in particular, one of the things that we have been doing is over the past year, really doing a landscape analysis of what are the existing partnerships between healthcare and housing and community development to understand what are some of the strategies that can be scaled or built upon, and what are some of the gaps or opportunity areas. So we'll be putting out something on that, hopefully by the end of the year, if not in January, and we'll make sure to get it out through this network because we looked both at some of the work that's been going on in other regions, like talking to Melissa and hearing about some of what they're doing, looked at some of the national work, and then in particular talked to a lot of our local stakeholders. A couple of things that we found in the housing area in particular is that we do in Chicago and Cook County have a lot of good momentum and models around partnerships related to permanent supportive housing and health. We have a new flexible housing pool here in Cook County that has really been led by Cook County Health, which is our public health system, as well as UI Health and Advocate Aurora Healthcare and some others. And then we do have a community development finance institution, the CDFI, which is CSH, that has been helping to lead that effort. And that's a really the flexible housing pool is a really interesting model that is looking to braid funding across public, private, and so government, healthcare, and other private sources to increase the supply of permanent supportive housing and build on some of the care coordination and housing tenancy supports that have already been happening in our region. Also, a group of hospitals and community partners called Westside United, which is on the west side of Chicago, has been doing some really interesting work around developing a small business grant pool. And so if anyone is interested in more information about that, that's also been done through a CDFI and with investments both by healthcare institutions as well as other financial and foundation partners to be able to support small business grants to folks who are looking to start new businesses on the west side of Chicago. And the last thing that I'll just mention as an example is that several of the healthcare institutions in our region are part of the Healthcare Anchor Network, which for those on the webinar, probably some health systems in your area are part of that as well. And there was some new investment commitments that were announced, I think 2 weeks ago through the Healthcare Anchor Network. So that's another place for folks to look to get a sense of which health systems and importantly health insurers as well are starting to think about how to invest in community development.
That's great. Yeah, I think the health insurers is an interesting example because they're incentivized to keep the local community, their members healthy. And yeah, why don't I have my team link through the Healthcare Anchor Network website, because that's a great example. You got 45 healthcare systems, and a bunch of them just recently committed to, I think it was like $700 million total across several. Catherine, yeah, let's talk about Atlanta and how you're interacting with the community development corporations and CDFIs and other organizations.
So it was apparent not only in the way our data-driven process and stakeholder engagement to set the priorities, but also as we have been working with residents directly since 2012, that economic opportunity is how our community sees advancing health. So the data showed it, and every organization, neighborhood that we are involved with continues to say that essentially if they had better economic opportunities, they could have a better health. And so that direct link to economic development, economic opportunities is not just from the fancy computer model we got to use and the data and all the professionals we heard from, but there is not a community-led effort that we are doing that doesn't put jobs and good schools and access to economic, a good economy at the center of what it takes to be healthy. So to that end, we have continued to work on how to drive some of those investments together. And it happens in a very practical way with some of the interventions we are helping to foster, which address the unmet social and community needs of individuals with certain health diagnoses, and we're able to track and demonstrate real improved health outcomes. So demonstrating that what we all know works is really working patient by patient here in Atlanta, working through the kinks of building those operational bridges between the health sector and the community and social services, job training, education supports, because it's easy to talk about building those partnerships, but to operationalize them, and since we're planning to be here for 28 years, operationalize them and sustain them, that's significant work. And so that is on one side. And then the other, I mentioned that because we have the longer time horizon, it has allowed us to more closely align with the economic development strategies, which are not short-term in our community. They do look to a longer time horizon, and that's been incredibly helpful. And then most recently, Melissa mentioned that we are in a partnership together, and that has helped us drive some significant progress of health systems actually moving toward understanding how other regions have invested health dollars in community economic development. So we've been through a year-long learning journey with them and are moving toward turning that into an action plan that will include investment dollars. So that has been critical. I would say too, just that, and this is what everybody I know knows, but it can't be said enough, that at the heart of this continues to be about relationship building, trust building across those two sectors, and learning how to live in each other's space. So for the last 2 years, I have chaired the board of a local CDFI. So my job is to lead a health collaborative, but by working together in those intimate ways, building relationships, finding ways to support each other first before sort of talking about the two-way street has been very helpful as we have continued to do that. But I would say there's still a lot more work to be done.
That's really helpful. And we just chatted through the link to Spark, so folks can learn more about that. And I didn't realize, Catherine, that you're on a CDFI board. I think that's often something I say that is a short-term next step is take those opportunities. And similarly, getting a banker or a CDFI or CDC leader on your own advisory board as well can be really helpful. I'm on the board of Mercy Housing. So here's a physician who does population health on an affordable housing developer board, but it really helps, I think, us all understand one another better. So I've got a question here. This one is for you, Melissa. You ready?
I am.
It's actually a very specific question. So how was there a systematic way in which you gathered areas of expertise across the counties that you mentioned? Or was it more just sort of recognizing, how do you identify who are experts?
Yeah, so the counties themselves had, as they moved over the years into doing more work on social determinants, had decided where they were going to focus and hire. And so we have a couple of really strong climate change experts in a couple of the counties. We have some really strong housing folks in another handful of counties, really strong economic development people in others. And so we host a monthly general membership meeting that is topical. And so it draws public health staff with that interest in that particular topic, and we can identify some people there. We host monthly communities of practice on the built environment, one for epidemiologists, one for middle managers, and one for senior managers. And that also is another place where we identify people. And then those members, as we're launching new projects, will identify people in their public health departments who are fans of equity and believe equity is important and want to drive it forward. And then they join our projects. I'll say the last thing is each health department appoints to our board a member, and that member is also charged with helping figure out who is the right person for different projects that we advance.
That's great. Okay, so you have sort of multiple levels to let expertise rise to the surface and an intentionality around identifying it when you see it. That's really helpful.
Yeah.
Okay, so this is a question that came up both in the registration process and just now, but let's talk about gentrification. This is always on the minds of folks. So what about the risks, and does taking a regional approach help mitigate any of the risks of gentrification? Anybody want to answer that one or start first? Maybe Catherine, I'll turn to you if you don't mind. I think the Atlanta Beltline has raised a lot of concerns. Yeah, I'll just say that. And so, I mean, it's so great, and yet there is a risk there. And you being a regional effort, is that helpful, or how do you think about gentrification?
So I think it has really emerged in a number of key ways for us. And at the start, it really began with a recognition that once we can see gentrification, we've really lost the opportunity to intervene. And that it really, the biggest frustration that our partners share is that we keep relearning the same lessons about gentrification, and that's really getting to be a shame on us at this point, because these things are more predictable than we have allowed them to be. That being said, when I mentioned that our resident-led work really tends to say, if it's about having a better job, and that's how I will be able to be healthy. We have focused intensely on those areas of our region that, despite our region having a less than 4% unemployment rate, still have unemployment rates of 12 and 18%. And where we are in this economic cycle is just remarkable that we have very likely, once again, left whole areas of our region behind. Those same areas are not yet experiencing something to be called gentrification, and so it's an important area to intervene and to be able to look at the resilience that folks will need as our economy continues to change and evolve over time. So that is where, in all of those instances, to be able to build up some of that resilience, we have a couple of core things in those interventions. One, thinking very comprehensively about folks' needs. So if we just address their housing, but not their jobs, and not their transportation, not the child care, not the education, it's not going to work for folks. They're not going to have what they need to be able to participate in the economy and survive the ups and downs that are inevitable. And so all of those models look more comprehensively, and all of them invert the burden away from the individual and family back to the system itself. So we have recognized now, this many years into our effort, that way too much in our region, we just put this huge navigation burden on people. Say, these are all the services you can access, but essentially good luck getting them. We have huge hurdles that people have to overcome to coordinate all of that. And again, if one need is met, that's one need being met. It doesn't create that ability to both engage with the economy and then survive its changes. So the themes that we have been is trying to get where people are out ahead of any of the economy, and then to shore up the community and individuals living there with the resilience they need to be able to survive those changes. But, the example you gave, like the Beltline, the biggest issue is that was very, very predictable, and yet we didn't do anything. And now there's a lot being written and studied about it, but it's not going to be able to be corrected in any substantial way.
Mm-hmm. Yeah. Justin, Melissa, do you want to add? That was a lot. Do you want to, a lot of good stuff. Do you, anything specific to add so we can get some more questions?
Just that this is such an important question. I think it's one of the most pressing for our region right now, and we're taking it quite seriously. And for us, we felt that regionally we needed a set of solutions, and that they couldn't be advanced across 101 cities one at a time, but we really needed a strategy that would advance across multiple cities quickly. And that was our reason for doing the coalition building and engaging in the coalition that passed the statewide work.
The last thing that I'll mention is that we have recognized both as public health and healthcare that if we're going to use life expectancy gap as a metric that we're looking at, that we really need to behind the scenes be tracking metrics around leading indications of gentrification and displacement, because you can solve the life expectancy gap by displacing folks with other people without having actually improved the lives of people who were being impacted by that. So that is definitely something that we're working on to make sure that as we're measuring life expectancy as a leading indicator, we're also looking at making sure that that's not happening through displacement.
Mm-hmm. Yeah, and a colleague of mine, some of you may know Carol Naughton at Purpose Built Communities based in Atlanta, that she talks about plan for success. Is that if you're doing community investment or like the Beltline, it probably at the time can seem unimaginable that there'd be gentrification pressure, and yet if you're successful as you hope to be, there will be. And it's Catherine, you put it really clearly. We know these things happen. If you make a neighborhood, if you provide more resources in a neighborhood, people will be more likely to want to move there, and that just happens automatically. So what can you do to make sure the residents can stay? And I think something that I've been thinking a lot about recently is the issue of cultural displacement. In addition to actually forcing out the individuals, it's rolling over the local culture that can, I think, feel as disorienting as the actual displacement of humans themselves is eliminating the history and the culture of a given neighborhood. So let's see here. Here's a question about outcomes. So we've had a couple questions about outcomes. Have you seen outcomes to date on your work? I'm going to ask you two, actually. So one is around the issue of outcomes. The second is about maintaining stakeholder engagement over time. Unrelated questions, but maybe just to get us rolling, you can talk. So it's stakeholder engagement over time and outcomes. They're kind of related in a sense, but go ahead. Who would like to tackle one of those or both?
Yeah. So I am a big believer around stakeholder engagement needing to be refreshed over time. And so there are some folks, I think, who like to run committees and communities that and communities of practice that run in perpetuity. I actually think shorter term communities of practice can be a great way to engage people on short-term projects. So we have 3 cohort training series that we run that are just 6 months long, once a month, that are a cohort-based way for people to get to know each other, to learn the issue that they're trying to implement and get support on trying to implement it. And then it ends and we change it into something else. And that keeps people engaged and keeps bringing to us new people with new projects that they're trying to move forward. The other thing that I think is important around engagement in something as large as a set of health departments is we do some trainings that we do department-wide for folks, so that many people get to know the social determinants of health, get to know a bit about us, and then can understand and engage with different parts of our program that are on our website or that we advertise through our newsletter. And those 2 things I think really help. We also do very informal lunches once a year with leadership in the health departments, where we have parts of the sub-region where we all get together for lunch and we just have a conversation about what's happening in those counties, in those health departments, and then we shape our annual strategies around what we're hearing there and what we're seeing in our other different activities.
Mm-hmm. Good. Things to add, Catherine or Jess?
I would just maybe offer, maybe picking up on the theme of eating together a lot, that one of the things we started when we didn't have a name or we weren't sure what we were going to do, but we just thought we would see who felt the same way. So we called together people for breakfast, and then it fell into a rhythm that we happened to do it 4 times a year, which started to become a quarterly breakfast. And in a couple of weeks, we'll be celebrating our 31st quarterly breakfast. And what's been helpful about that is that it occurs on a regular basis. It's a very low bar to entry. There are enough people so that if it's your first time, you don't feel very uncomfortable, like you're the odd man out. And we provide, we've worked over time to create an atmosphere where when people just want to start to engage without making a big commitment, it's a really nice entry point for them to do that. And then it gives us the opportunity to follow up as appropriate. So I would say, just for our purposes, we've been surprised at the many uses that breakfast has had for both momentum and engagement, I would say. Just on the outcomes, I think the areas that we're most proud of is having effective examples of cross-sector partnerships that have worked, and also demonstrated instances where competing interests were willing to pool resources. So those are more on the process side, getting us to longer-term health outcomes, but they are kind of those radical changes we're looking for in how our current big health ecosystem is working.
That's great. Yeah, process measures with the knowledge that they're process measures, but going towards longer term impacts. Yeah. Anything quick to add, Jess? I want to try to get to one more question.
Go ahead.
Yeah, okay. So I'm going to raise 2 again for you guys and let you just pick what to bring up. It's also partly just to let the audience sort of hear these questions. So one is a question of how these types of strategies might work in less urban areas. And that's, again, a little bit outside your perspective, but rural frontier communities. And the second is around specifically addressing racial equity and structural racism. Certainly, Melissa, it's core to Barfight by definition, but yeah, so rural and race, 2 giant issues, but maybe just a few words from you guys.
Sure.
I'll start since I didn't chat on the last one.
Oh yeah,
so
that's a good point. I should have turned it to you, yeah.
No worries. So for rural, I would say one of the things that I was thinking about for stakeholder engagement, I think really also holds for rural communities is, particularly when you're thinking about it in a regional context, is we really have to have strong skills in being able to bridge in-person participation with folks who are participating virtually in a meeting. So we've found that it's really important to be, one, to move the meetings around the region so that even though, you know, a concentration of folks might be in Chicago, we need to also hold meetings in other parts of our county. And I know that that also holds true in the rural work. So I think a lot of the things that we talked about in terms of the relationship building and how to engage stakeholders in ways that meet their needs and abilities to participate, I think often really plays out also in the rural context. And as a statewide public health institute, we have other work in those areas, but it's not the work that I lead.
Right.
In terms of structural racism and racial equity, one thing I'll just mention is that we did invest in having one of our staff participate in a year-long fellowship on racial equity here in Chicago. And we're working now to think about how we can sort of create a similar type of opportunity specifically focused on some of the healthcare partners that we're working with. And a lot of the things that have come up from our healthcare partners who have specifically named structural racism as a priority within their community health strategy, which is a number of them, is really figuring out how to balance the work that needs to happen internally within large institutions to acknowledge and address the role that these large healthcare institutions have played and continue to play in issues of structural inequities and perpetuating structural racism, and then also how to partner across healthcare institutions and community partners to also really shift some of the power into community-driven efforts, and that doing that internal and partnership external work, we have to be doing both of those at the same time. So anyone who has good models on how to do that with healthcare partners, we're looking for that too. So please reach out and let us know how you're doing that work.
That's great. That's really helpful. Why don't we, Melissa and Catherine, if you don't mind, I want to turn to just final comments from you guys. So if you have anything to add around the structural racism or, and inequities or rural, we can leave that into final comments. But I wanted to give the three of you an opportunity to sort of wrap up, raise anything you've seen, and then I've got a couple closing comments with resources and stuff. So maybe Catherine, do you want to start? Just closing comments, anything brief?
Yeah, I guess I would just say that I have found doing this work the last couple of years that these kinds of experiences, just like the last hour we had, can be so incredibly helpful and powerful to build relationship outside of our region, to be able to get new ideas and the sort of momentum to keep moving forward. I think even though I've been talking with Jess and Melissa for quite some time, I wrote down like 5 things that they said today, and it's so powerful and helpful. So I appreciate the opportunity to gather. I would also say that I think similar to what Melissa said, that everything we have is up for grabs as long as you guys are all willing to share everything with us. So we are very much about stealing other people's great ideas and using them here. And I think everyone who's been on this is in this together. So thank you for the time and the opportunity to connect with everyone.
Great, thank you. Melissa, final comments?
Yes, so I think the value of these regional networks is how much we can personalize them to our own needs. And so for the issues of rural communities, smaller jurisdictions, I think it's a really interesting opportunity to think about how to get to some shared economies of scale on staff that you might otherwise not have available, or staff expertise you might not otherwise have available to your jurisdictions. And so I've had some conversations with smaller communities about thinking about regional collaborations that would allow them to do more grant writing and compete more effectively for federal grants that could increase their capacity, et cetera. I think those are important things. So I think I'll share just as some parting ways, some things we have to offer in case you're launching this work locally or moving into the next phase of your work on that. On racial equity and health equity, Barfight has put together a toolkit to help local health departments and state health departments identify their capacity strengths and their gaps to advance racial equity practice. And so that's available for free on our website. It's the Barfight Toolkit. You'll see it there. To focus on racial equity efforts and really help advance a racial equity policy stance, we have been developing a series of briefs on policy that include a real strong focus on racial equity. And the one that I'll point people to also on our website is our federal policy brief on family housing stability and health that we released with the Federal Reserve Bank of San Francisco about a year ago. And then just also so folks know, we have a series of trainings on our website, including a bit of work that we do on racial equity, including an adaptive leadership series to advance racial equity that includes a focus on partnership between public health, government, and community. And so if any of those are helpful, we are always happy to chat with people about any of that. And we share information back and forth like we do with Catherine, and it enriches our lives, and we hope enriches other people's as well.
Great.
So
well, we are basically out of time, but yeah, I want to, go ahead, Jess. No, please.
No, I was just going to say, I wanted to say that we have a couple examples here locally of coalitions that are doing a really good job of engaging community resident leaders in healthcare decision-making. And so if anyone is interested in that, I would love to pass folks along to some of our colleagues at Proviso Partners for Health or Westside United or other folks who are doing that. So we're happy to do that as well.
Thank you so much. So we are at time, so I just want to thank the three of you, Catherine, Melissa, and Jessica, so much for all your expertise, taking the time, doing our prep calls, et cetera. This is incredibly helpful. I hope folks on the call or on the webinar reach out to you. I do want to encourage folks who are out there, continue using the Twitter hashtag Network Commons if you've got thoughts or you want to reiterate or restate things that you heard that you liked. We will be sending out a follow-up email that will have this whole video will be on YouTube shortly. We'll provide all the links that we talked about, and as well as some of our own resources. So please, one other resource that might be of interest to all of you is we have a monthly newsletter called The Pulse, which really tries to make this work fun and interesting. It's short, it's pithy. It's a way to sort of keep your finger on what's the pulse, what's happening. So thank you all. Thank you all for joining us online, and we'll look forward to following up.
Thank you.
Take care, bye-bye.
Thank you.